My name is Dr. Dorian J. Wilson. I'm Associate Professor of Surgery at the New Jersey Medical School. And I have with me today
Dr. Ken Swan. I'm Professor of Surgery at New Jersey Medical School.
Dr. Swan, it's a pleasure to have you here today, and I'm honored to be here with you performing this interview. What brought you into the field of medicine and medical education?
I think I'd have to say, can I call you Dorian?
Please.
Dorian. I'd have to say that probably my older brother was my inspiration. He was, at the time I was making decisions like this, he was Associate Professor of Physiology at Cornell University Medical College, but he was a board-certified internist, and he'd had a long, distinguished career in the Navy. And he essentially told me what to do. He was the oldest of five, I was the youngest of five, and he told me to go to medical school.
That's great. Are you happy with that decision?
Yes, it's probably the best decision I ever made. And I disliked medical school. Certainly the first 2 years I wanted to be a fighter pilot, and I'd applied for the Navy's Air Officer Candidate Program.
Are there any other healthcare professionals or physicians in your family?
Yes, I have a cousin who was an internist, older than me, and her husband is a urologist. I have a niece who was a psychiatrist. I have a nephew who's a first-year medical student at UCSD. And of course, I have my daughter is an obstetrician gynecologist, and my son is an orthopedic surgeon. My wife is a BSRN.
If you had to ask them the question about how they have reflected on your career, what has their experience been based upon their experience with you as a healthcare provider in medical education, how would you respond to that question?
Well, I think they look at the time devoted to it, and times have changed. Patients came first, family came second, and that seemed traditional. And looking back, I spent more time than I should have with patients and less time than I should have with children. They've reversed that trend. I was in the Army, so I had essentially two careers going, and they were all going to go into these services. My daughter applied to West Point. Son was going to go to the Air Force Academy, and daughter was going to go to Annapolis, but never came to pass. And at least my son has said he misses having served in the military because he knew it meant a lot to me.
Now, I know your son is an orthopedic surgeon. Is he involved in trauma at all?
Yes, he is. He's full-time down at New Brunswick on the trauma service. He takes calls 6 times a year. He's in private practice, but has a appointment at Robert Wood Johnson, and he does a lot of trauma. And he completed a fellowship in sports medicine at the University of Colorado, so he combines that with it.
Has he consulted you ever on trauma cases?
Oh yes, but less and less.
Okay. All right. So tell me, how long have you been practicing medicine?
Well, I graduated from medical school in 1960, so it's been 50 years, more.
Wow. What would you say is the most interesting or motivating factor of practice, particularly now that you've been practicing medicine for so long?
Well, for us in surgery, as you know, it's the technique of the operative procedure, mastering that, but of course it's seeing fairly prompt results of your treatment of a patient, and all of us, regardless of our discipline, are here to so-called help people. And it's wonderful to see the solution to a problem and the betterment of the patient, recovery from surgery, and to maintain a long-term relationship.
What made you consider and pursue a career in trauma surgery?
Well, my family, as I mentioned, were all internists. In fact, they were very critical of surgery. And in those days, surgeons were condescending, arrogant, narrow-minded, supercilious, glorified carpenters and plumbers that just charged more for what they did. And that was what I was born and bred with. But internal medicine, I thought, was extremely competitive, and I was sort of anxious to separate from the rest of the family, and I liked surgery. After the completion of my training, I joined the Army under the Berry Plan and made a career in the Army, although a good bit of it was in the reserves, but I spent my initial 5 years after residency on active duty and had my first year in Vietnam. And having had no training in trauma where I trained at New York Hospital, Cornell Medical Center, it was an eye-opener to me, and it was a great training experience, and that's why I wanted to go to Vietnam. And I became very interested in it. It followed along with my research interests, which were in cardiovascular physiology and the treatment of shock and so on. And as you know, trauma centers began after Vietnam, and so it was a natural progression from active duty in Vietnam to the streets of Newark and the development of level 1, 2, and 3 trauma centers.
Mm. What was your observation about making that transition from the fields of Vietnam to the streets of Newark?
Well, velocity primarily. Vietnam was high velocity, and that's an entirely different wound from low velocity. And I had to refine some of the techniques that I applied that I learned in Vietnam back to the civilian world because they were no longer applicable, such as debridement. Of course, we had mass casualties, so rarely do we triage in the civilian community. I learned triage in Vietnam, and triage is critical for mass casualties. And when I went to Desert Storm, for example, all the lessons we had learned in Vietnam had been forgotten. We had to relearn triage. I was able to, therefore, bring it right up to snuff in a very brief period of time because it's a simple technique.
Were your associates happy with your prior training and the wealth of information that you brought?
Yes, indeed, they're very appreciative because combat casualty care is relatively straightforward. That's a pretty glib statement, of course, but triage is critical, dividing into the walking wounded, the vast majority of casualties, the expectant, those who probably are not going to survive, leaving the priority, those who will probably survive, with a meaningful survival. And we had 61 Egyptian casualties one night in Desert Storm, and fortunately we had rehearsed triage and everybody knew their place. For example, the triage officer never treats. He only sorts and retriages going from the areas. And that was very helpful.
Well, we're primarily here because of your association with the American Physiologic Society. Can you tell me about your connection with physiology and in particular your connection with that organization?
Yes. I mentioned my brother earlier, and he was my guiding light, although he was more of a father figure than a friend at the time, but he told me essentially what to do, and I followed his advice very carefully. He was a great role model. I was interested in research, and we had a brief period of research during our surgical residency, which was 8 years long. We had about 4 months in the dog lab, as we called it.
All right.
And I developed a little technique for measuring gastric secretion in a little rat model, a little Heidenhain pouch in a rat, and presented it to the surgical forum. My older brother said, if you're really interested in research, you need to go elsewhere. You're not going to learn it in this institution. And he said that in guarded terms, of course, because it's a famous institution.
Right.
He said, you need to go to a lab outside of this area, Charles Code in Minnesota, Mort Grossman in Los Angeles. And so I did apply, and Mort Grossman had a good friend at Cornell, and they said, you're going to have to spend 2 years there. I said, can't afford. The residency would never tolerate that. Mort Grossman invited me out to an interview. I interviewed in the airport. It was about 15 minutes. I got on the plane and came home, and I started there, and he was a great role model as an investigator and one of the most admired American physiologists. And it was a wonderful year that I spent with him, learning the experimental technique of the interesting question, the hypothesis, the experimental model, the performance of it, the interpretation of data, statistical significance, all that. And when I came back from Vietnam, I went to Walter Reed Army Institute of Research and spent 4 years there, and mostly physiological research. And I joined the American Physiological Society and realized there weren't many surgeons in it. It was an interesting organization for somebody who was long range, was a pursuit of a surgical career, not a physiological career. You could combine the two.
How were you accepted, being someone that was largely different from the majority of people that were involved in the society at that time?
Well, the society is very ecumenical, as you can well imagine, and if your work is acceptable, then you're acceptable. It's based only on your research.
Would you recommend a similar experience to others?
I would, but as you know, today, even in our own program, it's very advanced in terms of residents going into research and spending 2 years in the laboratory within the residency. In my case, that was not available, so that research is much more sophisticated in surgery, and I think the barriers between the two fields are much more disparate. We're doing physiological research in surgery.
Understood. Now, your history and your life has been marked by participation in the United States military. Can you tell me how that started? And
Well, growing up during World War II, I was very admiring of all those in uniform, and as you may recall back then, no, you wouldn't recall, you weren't there then. But if you came home on leave as a service person, servicemen in those days, you were in uniform everywhere you went. If you went out to a party, took a date somewhere, you went in uniform. And of course they were...
Even when you were on leave away from service?
Absolutely. If you were out of uniform, there was something wrong with you.
Okay.
So I admired my brother, and he was a submariner and a torpedo and gunnery officer, and he left medical school to do that. So I always did admire the services. And yet another brother is in the Navy, and he's in the Naval Air Force, and I didn't want to compete with them, just like I didn't want to compete with the internists. So in any event, during the Vietnam War, the draft was still in place, and the Berry Plan was also developed to face the draft of physicians. If you agreed to a specialty, and I picked surgery, and if you picked a service and I picked the U.S. Army, then you were accepted with the usual provisos, and you were left alone during your residency training, but you owed 2 years when you completed your residency. The Army had much more resources for medicine and surgery. It was an obvious choice, and I wanted to learn about trauma, and I knew I wasn't going to learn it where I was. So it was easy choice, but the problem was, because I had done research out in Los Angeles with Mort Grossman and Gene Jacobson, another famous physiologist in shock and blood flow, the Army assumed I was a scientist, and they assigned me to Edgewood Arsenal to study wound ballistics, which I had no interest in, curiously enough at the time, but later did. So I went to Washington and said I wanted to be assigned to Vietnam, and I wanted a surgical hospital for far forward where I could learn about trauma. And they reassigned me, therefore, to the Walter Reed Army Institute of Research and its surgical research team in Vietnam. And I had to go back to Washington and say, I really don't want to do research in Vietnam. I want to take care of combat casualties up front. And they sent me to see the psychiatrist because nobody wanted to do that. I had to have a screw loose. But I was able to convince the psychiatrist that I was on the level. And so I got sent to Vietnam. But as you can imagine, that caused a little disharmony on the home front because I was married, and we had just had our first child.
Right, right.
So it was a great experience, and there was so much to learn in the military and so much to do that I decided it was a career and I might stay on, go full time. But after 4 years of research at Walter Reed Army Institute of Research, I realized I was a physiologist, but I hadn't spent all that surgical training to become a physiologist. I missed taking care of patients, and there was no way I could do that in that current position, so I had to leave. But I went in the active reserves at that point.
Now, someone in your position, having reached the rank of full bird colonel and having done 3 tours in Vietnam, did you ever get a chance to meet with any of our United States presidents?
Yes. Well, yes, when Ronald Reagan was shot, that was 1991, I was called and asked by the news media. I had just finished a book with my older brother on the subject of gunshot wounds, and I was asked for an assessment of what the prognosis was. And I said, well, it's a small caliber handgun, medium caliber handgun, and muzzle velocity is low, kinetic energy is not much. It's in his chest. They'll put in a chest tube. He'll drain some blood out of his chest tube, and they'll take that out after a few days. He'll be fine. And I told them about the principle of managing penetrating chest trauma with tube thoracostomy. And they listened to all that. And they said, can we call you back later on and talk some more? I said, sure. So as a matter of fact, I was in the laboratory working on a project with some medical students and residents, and I got a phone call. They said, hey, you told us that this was a simple therapy. They've operated on the president. I said, what'd they do? Well, they apparently opened his chest and his abdomen. Mm. Well, I said, there's more than meets the eye. Then something else has happened that you didn't tell me about. And I called the surgeon down at Washington National Hospital, where the president had been taken, GW. And he was a friend of mine from the Army. And I said, Joe, I don't understand. The president had a gunshot wound to the chest. It sounds to me like a chest tube would have solved that. Well, we learned that it was an exploding bullet and that it was a poisonous bullet and that we had to take the bullet out. And I said, but now how about this diagnostic peritoneal lavage that you did? Well, he said that was, I can't comment on the thoracic surgery, but we thought it might have penetrated his diaphragm. And I said, but the resident usually does that. Well, this was the president, So both took severe criticism for over-operating on the president. Right. And the bullet was packed in pulmonary parenchyma, so it was unlikely to explode.
Has that bullet found its way to the Smithsonian?
I think so.
That brings us to another point. You're a ballistics expert, and you've written a book on gunshot wounds. Can you tell us more about that?
Yes, well, my father was sales manager for Remington Arms, so we grew up with a lot of guns in the house and still have a lot of guns in the house. And I've enjoyed the sporting use of guns and so on, and I enjoyed the weaponry that I was exposed to in the Army. And having seen a lot of gunshot wounds and having taken a second tour of Vietnam where I photographed gunshot wounds for a 3-month period, I decided that there was so much misinformation about the management and the weapons that it would be worth putting together a textbook going through the systems. And I needed a co-author, so who would I have? I could invite a whole host of authors to write about the various sections, a urologist to do GU. I really didn't want to do that. It was simpler than that. So I asked my older brother if he would join me. He's an internist, he's an anatomist, and he's a physiologist. And he's a smart guy, and he became my best friend, my most important mentor, and my finest associate in research. So we put together this book on gunshot wounds and dedicated it to my father. And Roy said we were working at my house, which we did once a week. And he said, you know, we're going to have to write a dedication. Who do you think we ought to dedicate it to? The wives? That's what's usually done. Or he said, how about Dad? And I said, oh, Father was dead at that point.
Right.
I said, I think that's one. He said, do you want to do that? Do you want me to do that? And I said, no, I'll do that. And so I wrote this long salutation to our Father, and I gave it to him all typed up, and he read it all. He said, oh, Ken, that's magnificent. Dad would be so pleased. Do you mind if I take a crack at it? And I said, no. What, you couldn't say it to myself. You couldn't say anything more than I did. I didn't leave anything out. All Dad's associates in Washington's. He was #1 skeet card of the American Skeet Association. He founded it, etc. He went into the dining room where he worked. He came back about 2 minutes later and threw a piece of paper in front of me. And I knew I'd lost again. On it said, to our father, Roy C. Swan Sr., whose vocation and avocation generated in him a passion for the safe handling of firearms.
So you have a copy of the book there. Why don't you show it to us?
Here it is.
Thank you. Now, research has punctuated your career since the very beginning. And I understand recently you talked about your research with your brother in terms of doing this book and your research with the American Physiological Society. I understand you've taken a novel approach to research in terms of inviting others that you know very well into your research team. Can you tell us more about that?
Well, yes. As you probably know from out of the Middle East and the U.S. involvement in war there, one of the #1 causes of wounding is extremity wounds from improvised explosive device, IEDs. So extremity wounds, true in all wars, are a major source of hemorrhage and loss of life. And after each war, for example, after Vietnam, we say that the majority of those that died exsanguinated on the field. Of those, 20% were extremity wounds. And half of those, the life could have been saved by simple measures, i.e. control of hemorrhage in the field. So that brings up the subject of tourniquets, which goes back to ancient times, and they have been abused and misused over the centuries. And it became clear that some definitive statement about the use of tourniquets was appropriate. So we studied the application of tourniquets on upper and lower extremities. For example, tourniquets below the knee or below the elbow are thought to be ineffective because of the 2 bones and multiple arteries in those parts of the extremities. You could not compress the 2 bones.
Ineffective, you said.
Right. So therefore, you had to put the tourniquet above, and of course that would end up oftentimes leading to loss of joint. So we studied the 3 tourniquets, the cloth with windlass, the traditional cloth with a stick, and the pneumatic tourniquet, which is a blood pressure cuff, and the half-inch rubber tubing, which was the most popular tourniquet, most successful tourniquet apparently in World War II. And we found that all tourniquets work, as all tourniquets will work in either location, and determined by the elimination of the pulse, Doppler pulse signal in the foot or the wrist. And my co-authors were my son, he's the first author, and my daughter, she's the second author, and another daughter is the third author, and my wife is the fourth author, and I'm the fifth author. And so it was a family project, and the family were the subjects, but we needed more than 5 for statistical significance. So we needed to reduce the mean age to make it acceptable because we were a little bit older. So we studied my wife's sister's family, teenagers up in Wyalusing, Pennsylvania. And so it's in the Journal of Trauma, and it's I think probably my proudest publication because of the family involvement.
Dr. Swan, what would you say have been the highlights of your career?
Well, Dorian, I would say, of course, the fellowship in Los Angeles in GI physiology. And I must remember to tell you a story about Mort Grossman.
Very good.
That certainly started me off into the academic world, which is where I found a great deal of satisfaction as opposed to private practice, although we can do both, of course. I think the military career is certainly a highlight. What was more important to you, the U.S. Army or medicine? Well, I'd have to say medicine, of course, but U.S. Army comes very close. And then there were, I'd have to say, the highlights of my career, you said?
I did.
I'd have to say my marriage to my wife.
Very good. That's Betsy, right?
It's Betsy and our 3 children, and she was very gracious during my initial trips to Vietnam, not very gracious on my second trip to Vietnam, and I took her with me on my 3rd trip to Vietnam, and then it all fell apart when I went to Desert Storm.
Very good. Okay.
So we had a wonderful trip to Alaska. The Army had rented me out to the Navy. The Navy needed somebody in their Arctic Research Laboratory in Point Barrow, Alaska, to study cold acclimatization. They needed somebody who could work with blood flow, and that was something that I was doing. So we spent a summer up in Alaska with our 2 children at the time. That was a great highlight. I think, of course, working in a level 1 trauma center has been the main focus of my, what I consider most educational, most opportunity to educate, but best opportunity to do research, and certainly is the most important highlight of my career is trauma care, and it was the source of lots of clinical research and lots of laboratory research, and a book on gunshot wounds that primarily came from Vietnam, most of the care, but also was directed to civilian combat casualty care in the inner cities, in the level 1 trauma centers. I would not want to neglect Boy Scouting, because that's been a big part of my life and still is. I will remain active in Boy Scouting forever. And I'm an Eagle Scout, and don't want to leave church out.
Of course not. Of course not. You were highlighted, I believe, some time ago.
2020.
2020.
Yes.
What was that? You had a special relationship with a patient. Can you tell us about that?
Yes, I can. Now, if I pause and shed a tear, you'll know that it was not purposeful.
Sure.
Well, I was in country in Vietnam in my first month. And I remember I had arrived in Vietnam knowing nothing, although I was board eligible in general surgery and cardiothoracic surgery. And in fact, my very first night on, they said, "Why don't you get used to the..." No, I said, I'm here to learn. You want to be called tonight if we have casualties? And I said, yes. Sure enough, generally the enemy snuck in the wire as soon as the sun went down. That was around 8 o'clock. And the fighting started around midnight, when they got all their gear ready, and the casualties flowed in around 2 a.m. So at 2 a.m. I get a call, "Come on down." And the first patient I was assigned to, I did the usual history and physical, and I was pulled aside out of line and told that I was making too many mistakes, which was a crushing blow for all that training.
Right.
And I didn't know whether to laugh or cry at the time. So I was told to stand in the corner and watch for 2 weeks. Very humiliating, but being a good soldier, I did what I was told. And at the end of 2 weeks, they let me back in the fray. About 2 weeks later, I was the SOD, Surgeon of the Day, and it was late afternoon, I guess, and I was at a coffee break, and a nurse came running in and said, "Doc, we need you right away. There's a badly injured GI."
And what year is this?
This is 1968, September. And I didn't hear the helicopter come in. They all came in by helicopter. This is the 71st Evac Hospital in Pleiku, and we're in support of 4th Infantry Division, and the battles of Dak To and so on are right around us. So here was this door gunner of a Huey gunship, and he really had been blown to pieces. he was awake and alert and a nice-looking young man. And he said, "Doc, I think I left my legs on the helicopter." And I looked at his lower extremities and I thought, you might as well have left them on the helicopter, because they were really badly wounded from a B-40 rocket that had hit the helicopter. And he had a frag in his left eye that was in the right side of his frontal lobe by radiogram. We had a skull x-ray. And he had open fractures of both elbows. He was missing his fifth finger and right testicle. And I took him to the operating room, and we did a above-knee amputation bilaterally. The neurosurgeon did a craniectomy and debrided his frontal lobe. The ophthalmologist took out his left eye. And the orthopedic surgeons worked on his elbows. The neurologist came in and worked on his testicle and took that out. And it was a lot of surgery, but he survived all that, went off to what would be an ICU, but it was a recovery room that was ultimately built up to an ICU. And as I was heading back to my place, the chief of professional services, who was a friend, put an arm around me and said, "Brother Kenneth, I think you know that the fellows," he was from Arkansas, southern accent, "the fellows seem to think you should have let that boy die." And I was crushed. I thought, wow, I worked so hard on him. I said, well, I was trained to treat the sick and the wounded. God will decide who lives or dies. And that seemed to be satisfactory. I don't know who said that, but somebody must have said that somewhere along the way. And I realized that I had made a tragic mistake, but people were not openly critical of me. They were just sort of looking at, that was expected, you know. He was with us for about 5 days, then he was transferred to Japan. But in those 5 days, I learned that he lost the vision in his right eye. So now he's blind. And I figured he probably died along the way. Our casualties were flown to the 106 Field Hospital in Yokohama. And that was the end of it. But about 3 months later, the mail carrier, who was a friend of mine because we had a football team and we played football together, he came to see me, and he knew about Ken McGarity. And he said, "Hey, Doc, I heard Ken made it home okay." And my parents seemed to be told me. So I guess word got around, but I was crushed because I thought, oh my God, what's going to happen to him? He's going to be he came from a poor farm family. He's going to be in a farmhouse in a back room, aging parents looking after him, cigarette butts, can of beer. What did I create, a monster? Or he's in a VA, essentially, same thing. And I got very depressed about it. In fact, so depressed that I just locked it out of my mind. I displaced it, displacement in psychiatric terms. I didn't think about it until sometime later when I was here in New Jersey in the late 80s. A newspaper reporter for the Medical World News called me and said he'd been referred to me as somebody he was writing about trauma care, and he was referred to me as somebody who had seen trauma care in Vietnam and now trauma care in the civilian community, and comparing the two. Could he come up and interview me? So I said, sure. And he came up. He was a nice young man. And of course, the interview, he said, what was the worst thing you ever saw? And suddenly the recurred. And I blurted out this story. And I thought, wow, it was some 30 years later. 20 years later. Yeah, 20 years. More than 20 years later. So he published this article on it, and then he called me back and he said, so what happened to him? And I said, I don't know. Well, he said, where is he? I said, I don't know. Well, he's your patient, isn't he? And I said, yeah, he was, but a long time ago. Is he still alive? I said, I don't know anything about him.
All right.
Well, can we find him? I don't know. So, but that started a search for him. Meanwhile, Desert Storm was heating up. I went to Desert Storm and I pleaded with the Army told me they had found him, but that's a carefully guarded situation. You are not permitted contact with him until they sort everything out. But I said, you know, I'm going out to fight another war, and I really need to know whether triage is still the appropriate thing to do. And this was triage. I was trying to push them a little bit, and they said, Doc, we're getting ready for that war too.
Right.
We were pretty busy. But when I came back from Desert Storm, we were able to find him. And I said, you know, he's my patient. They said, he was your patient, Doc. He's no longer your patient. Well, we will contact him, and then we will contact you as to whether he's willing to see you, as to whether we think it's appropriate for you to see him. All this bureaucracy. But they eventually said yes, and I called him on the phone and talked to him and went down to see him. And then 2020 got a hold of it.
What kind of life did he have? I understand he got married, had children. And
Yes, he did. Oh, that was the funny part. I had called to the DOD, and they called me and said, we found your man. I said, oh, really? Good. Yes, he's alive and well. He's likes to scuba dive, and he's married and has 2 children. Wait a minute. I said, wow. And I hung up. I called him right back, and I said, wait a minute. He's got no legs. Can't move his arms, he's blind. He can't possibly scuba dive. They said, this is your patient. Don't challenge us any further on this. So he did. He married a lovely person, and she is in women's rights, and I think by now has her PhD in that field, and they have 2 lovely daughters. And he's, I thought, could be encouraged to go to college and to be in sort of supporting role for those with handicaps, and encouraged him along those lines, but he never did do that. He has subsequently succumbed to cardiovascular disease and diabetes.
So what did you come to conclude about your decision that you made in September of 1968?
Well, it was a good decision. Now, what would have been the situation had we had multiple casualties? As you know, without truncal injury, in other words, no injury to his chest, no injury to his abdomen, there's no reason why he shouldn't survive.
Right.
But then there's the bottom line. Is it going to be a meaningful survival? Well, you don't have an operative permit in the combat zone. You don't discuss with the individual, we think we can do this, that, and the other thing. You just say, we're taking you to the operating room. And no one ever protests that, because that's the system.
Right.
We are going to do what we think is best for you. We'll take care of you. We'll try and patch you up. No, Doc, don't do that. I don't want to, hey, I want to die. Let me go. We never let somebody go, because they're under the shock and trauma of their injury. So presumably they're not making an intelligent decision. Well, I'm probably a little bit emotionally charged with this
Right.
too. So question of who's right, and I can only guess as to what's best for him. So it was a lesson where those who criticized me, and they later reevaluated on 2020, they interviewed all those people, and they all said, you know, as it turns out, but if he'd done that in 100 cases, would that have been the appropriate thing to do? It turned out he's lucky. So there's a little bit of that there too.
Yeah.
But I know deep down inside that I was right, and I would do exactly the same thing again. And I would encourage others too. When you have only one casualty, you can afford to be a little bit more circumspect.
Well, that certainly is a great story, and it leads me to another point. It sounds a lot like, you know that we have a humanism center here at the medical school in which I'm involved, and it sounds a little bit like humanism played a role there, that special patient-doctor relationship. Can you give me your views on humanism and how it's played a role in your career?
Yes. As you know, we, sitting on the admissions committee, all those personal statements say I want to help people, and that's what we go into medicine for, theoretically. There's a lot of motivation. It's a great field. But ideally, we want to help people, and that can be considered very selfish, as a matter of fact, because who benefits when you help somebody? You feel good about it. So maybe you do it to make yourself feel good. Whatever it is, somebody gets helped. So it's easy to be, technically, theoretically easy to be humanistic. And yes, it's to make the patient better and to improve their medical situation is what we get the most enjoyment out of, I think, and feel the best about. And that should always be our goal, and hopefully always is. It gets challenged, as you know.
I'm looking at a business card that you gave me here, and conspicuously enough, it has your home phone number on it. You give that to your patients?
I do. And I have for a long time. And most of my colleagues criticize me for this, but I say try it if you don't believe me, because I've been doing it for decades now. And when I say goodbye to a patient or finish with a patient, and I say I will see you at such and such a time, but in the interim, if you have a problem, don't hesitate to call me. And I give them the card and I say, read the bottom line. And they read some other stuff. I say, no, the bottom line. They say, your home phone, you want me to call you at home? No, I don't want you to call me at home unless you need me. But you call me at home, night or day, 7 days a week. And if I'm not there, my wife will know where to get a hold of me. The interesting thing is, it's not abused.
Right.
Rarely is it abused. And usually when the patient calls you, they say, oh, doc, I'm so sorry to bother you, but, hey, slow down. Tell me what the problem is. It's something relatively minor that you can resolve, and it's instant humanistic satisfaction. And it goes as far as, hey, doc, my doctor's out of town. Could you refill my prescription for me? Well, you can really help somebody, and it takes about 5 minutes on the phone. If you call their pharmacy, you tell them in advance, I'm not going to renew narcotics, but if there's something that the pharmacist says you're taking regularly, even though it's not my field, I can quickly write a prescription and everybody's happy.
And I understand that in this modern age of healthcare and centralized medicine, you continue to make house calls.
I do make house calls. And if you want to have fun helping people, house calls are extremely enjoyable, and look how the insight you gain into the patient's situation. You see them in their home, and you also see how their family treats them, how they respond to that. And you can make it as long as you want to, but they are extremely grateful when you do that. And if you like helping people, that's a wonderful help. My patients recently have to come by wheelchair and an elaborate apparatus to get them to the hospital, so it is technically easier for all around if I go to their house.
Before I conclude with a question about what advice you'd give to people who want to follow in your footsteps, I remember you said you wanted to mention to us a story about Mort Grossman.
Oh, yes. Mort Grossman was known as the Shark. Although he was a very kind, loving, gentle man, he was very certain and very strict about the facts. And if you were going to convince him of something and had data, you better make sure the data has been well thought out. And so we called him the Shark because of what he would do to people at meetings, challenge them in the discussion period.
Right.
And it was you wanted to cringe a little bit when you saw it happen, but it was all correct. And so once at the fall meeting of the American Physiological Society, I believe, Lester Dregstead, who is a very famous American surgeon, but who was professor and chairman of the Department of Physiology and Pharmacology at Northwestern before he was professor and chairman of the Department of Surgery at the University of Chicago. And he was very famous for a variety of things. He had done the first separation of Siamese twins that had synostosis at the head in 1955 as a general surgeon.
Right.
And one of his interests was peptic ulcer disease. He presented a paper at this meeting, The Physiological Gastrectomy, Truncal Vagotomy. And he had done, I guess, about 100 patients where he'd done a transthoracic vagotomy for the relief of peptic ulcer disease that needed surgical intervention. And when he got down, Mort Grossman got up and said, gentlemen, the question before us today is not whether transthoracic vagotomy is a therapeutic procedure of merit, but rather should it be labeled a felony or a misdemeanor. And he sat down. And a silence came over the crowd as they all realized that Lester Drakestad, this famous surgeon, but also famous physiologist, had been destroyed.
Oh my goodness. All right, that's one for the books. So finally, in conclusion, what would you say to youngsters who want to follow in your illustrious footsteps?
Well, not my footsteps, but if they're interested in academic medicine, and it's so prevalent in departments of surgery today, even laboratory experience as opposed to clinical research. If you are interested, get exposed as early as possible, and certainly if you're thinking about going to medical school, that's good. If you're in medical school, that's better, but certainly during your residency, you better have solid contact with it and spend some time with it. Find out whether it turns you on or not, because learning the disciplines to do worthwhile research does take exposure to those who are doing it, and you will find role models and all the steps of completing the project and writing it up and presenting it, and manuscripts and rejection and all that. You have to look at all that and ask yourself, is that something that you want to do? And can you combine it with what you are currently doing, which is taking care of patients? And the answer, of course, is yes. So many people have done it, but get exposure early rather than late. And don't think that because you have to eliminate your educational debts and have to raise a family and all that, that you're going to be economically deprived as a result. You're not.
Colonel Swan, Dr. Swan, thank you. This
Thank
has
you,
been
Doyle.
terribly enlightening and
Thank you.
enjoyable.